All right, everybody who's signed on right now, I just want to let you guys know we'll be starting shortly. I see a couple of people have already signed on now. We should be getting going a little after 1 p.m. A little bit of housekeeping though beforehand. I just want to remind everyone who is here that React Physical Therapy is still open right now. We do offer direct access or free injury screens. So free injury screens means you could come into any PT clinic just for a free assessment. You can't do treatment, but you don't need to go through insurance or anything if you have some type of injury. If you're doing direct access, most insurance companies allow that. So that means you don't need a prescription from the doctor. It can come straight to physical therapy unless it's Medicare, but most major insurance companies do allow that. And then a couple other things. We have a therapist, Dan Foley, with us. He will be assisting me answering questions. So everyone's going to be on mute, but if you have any questions, just type it to Dan and he'll be responding throughout. And then at the very end, I'll also be doing a Q&A. And then next week, we have a therapist from our West Loop location, Garrick, who's doing a webinar on the effects of hip flexor tightness, and that will be June 4th, so the following Thursday here. All right. All right, so let's get started here. All right, so today I'm going to be talking about dealing with chronic heel pain, specifically plantar fasciopathy. And the reason why I wanted to do this topic is it's a very, very, very common condition. A lot more people are walking around right now, so they might be dealing with this ailment. I specifically have suffered it myself. And then even when I was first treating as a therapist, I really struggled how to treat this. And I think as the physical therapy community in general also does, and it causes people to have to deal with this for several months. And I'm going to argue that I think it's a way that we focus too much on the foot and ankle. We're not looking at other things that are happening elsewhere in the body that affect that foot and ankle complex. So we go along. So like I said, the main focus is just that plantar fascia. In most treatments, if you look at things online, it's all about stretching and releasing that specific tissue. And it's not really saying, well, why is that tissue getting tight in the first place? Why is it being overused? What's happening elsewhere in the body? What's going on in the knee, the hip, or the low back that's affecting that plantar fascia and causing it to be overused? So in order to understand that, we're going to go over a little bit of the anatomy and biomechanics of the foot and ankle. And then we'll go over things that are up the kinetic chain. So in different parts of the body that affect those biomechanics and lead to that strain on that plantar fascia. And then we'll, at the end, review some exercises that will hopefully be helpful for everybody. All right, so here would be the bony anatomy. And before I get started, there's going to be a lot of specific anatomy and biomechanical things I'm going over. I just expect everyone to understand big concepts that will be able to help you. So I might be throwing a lot at you, but just try to take away some big concepts, which I'll review. So if we look at the picture on the left, we got the foot and ankle. This would be the left foot. And we got the hind foot or rear foot in yellow, the midfoot and forefoot. And what we could appreciate is these two bones right here, our talus and our calcaneus, and that's your heel bone right there. And so this forms our subtalar joint. And so what happens at this joint specifically is going to affect how this part of the foot, how the midfoot and that forefoot move. And then if I'm looking at it from the top, here's the same thing, that talus sitting on top of that heel bone, that calcaneus. And then here's the midfoot and here's the forefoot. So looking at the subtalar joint, which we just talked about previously, is that heel bone with that talus. It affects the way our foot's positioned. So when our foot or our arch collapses, we have pronation. When we have a really high arch, we have supination. And when that arch collapses, in order for that to happen, you see this heel bone is going to slide outwards. And that's going to cause that midfoot or forefoot to collapse inwards and you're going to lose that arch. Here's normal alignment in the middle, and then here's the right foot. If you want to supinate that foot or have a higher arch, you see that heel bone's going to kick in a little bit. And so these mechanics, as we walk, we change from pronation to supination as we walk, and it's really important that that subtalar joint drives that ankle in the correct mechanics throughout the whole process. So, and this is the big thing which we'll repeatedly talk about, is that movement of that joint transforms that foot from a flexible shock absorber into a rigid lever. So when that foot first strikes, as you see that contact phase, when you first smack that heel down on the floor, you want mobility in that foot. And the reason why you want mobility in that foot is because you're starting to absorb all those ground reaction forces through the foot, and they would have nowhere to go if your foot was this rigid structure. So it needs to be nice and flexible so those forces could be absorbed in it. And in order for that to happen, you need pronation. So you need that foot, and this is an exaggeration, is you need that subtalar joint to go outwards, that heel bone to go outwards, that foot to collapse inwards. And then as we transition from that mid stance to then our heel lifting off to propel us forward, we want rigidity in that heel. And that rigidity is going to propel us forward. If that joint's unstable, you're not going to have a good ability to basically move and lift that foot forward. And so in order to be able to do that, our foot and the bones tighten up when it supinates, so that heel is going to kick in the opposite direction. So as we walk, we need a kind of a delicate balance between both of those. So let me demonstrate here. Hopefully it will make a little bit more sense. So when that left, this would be my left foot, when that left foot strikes the ground, this is when we want that pronation. So I'm going, I make that heel contact, and what is going to happen is my foot, that heel is going to kick outwards, that arch is going to collapse inwards to create that flexible structure to allow that foot to absorb all that impact when I drop my foot down. And then as I start to take the next step and lift that heel up, that heel joint's going to have to kick inwards, my ankle kicks outwards in order to make that structure nice and rigid and push off that. So we're going from flexible to rigid, and the way that happens, a lot is determined by that subtalar joint, whether we're supinating or pronating. And I'll explain how this ties in here to the plantar fascia in a second. So what is the plantar fascia? The plantar fascia is this piece of connective fibrotic tissue that originates in your heel, right? If we could appreciate this picture down here, and goes into the toes. And what it does is it helps support your medial arch. So if we look at this picture, we have this nice arch here. If we don't have a nice arch support, the foot can't be that rigid structure. The arch collapses, it's unstable, it has difficulty with those structures absorbing forces and whatnot. So that plantar fascia is there to create this kind of passive support for that arch. And it's crucial in reconfiguring that foot during the push-off phase to this more rigid platform through the windlass mechanism here. And so when I'm talking about plantar fasciopathy, it's usually this point tenderness in the heel right here. So if you're having pain in your Achilles or elsewhere, that's usually not it, and it's associated with a period of inactivity. So when you sit for long periods of time, when you first get out of bed in the morning, and then stretch that foot, that area right by where that plantar fascia inserts starts to be painful. So to kind of understand what the plantar fascia does, if everyone touched the arch of their foot, and what you're going to do is you're going to lift up your toe. And you see, as you lift up that toe, you're going to feel that plantar fascia, that tissue pop into your hand. And what happens there is when you lift up that big toe, that plantar fascia tightens up. It brings that heel bone closer to by that bone by your toe here, and it creates a higher arch. And so that gives that foot that rigid structure to help with that propulsion phase. Then that plantar fascia could also be stretched out in the other way and be elongated. And like I said, we want a delicate balance between these two. So why does this tissue, why do you get plantar fasciopathy and why does it become painful is basically any tissue throughout the body, any muscle or connective tissue, if you place excessive tension on it over long periods of time, that tissue starts to get irritated. And that's either from repetitive overuse or repetitive stretching. So we need this balance of that pronation or supination, that ankle rolling in and rolling out. And if there's too little or too much of either, and if the timing's not right, it's going to strain that plantar fascia. And you could see every single step, if that cycle's off, it's going to strain that plantar fascia. So the other big thing is, and this is in the physiotherapy community, there's no one person is treated the same. So, you know, people who have low arches have what we talked about, too much mobility because you're pronated too much, and higher arches have too little motion. So those two types of individuals need to be treated slightly different in their physiotherapy. So this would be that foot flat or pronation. We could appreciate that heel or calcaneus sliding outwards, that arch collapsing inwards, and that's that heel. And this is when that foot reaches that contact phase. And if it's still collapsed in or excessively collapsed during that push-off phase, it's not rigid. You don't have that windlass mechanism. That plantar fascia is getting overstretched and it doesn't have a chance. And so why does that happen? What could be occurring that's elsewhere in the body that's making that joint collapse inwards? And the big things we'll talk about is either you just have naturally a very pronated or flat foot. There's a history of ankle sprains, tight calves, your glute muscles are weak, or your back's tight. On the other end of the spectrum, if you have limited mobility, so let's say you have a higher arch foot, that structure tends to be much more rigid, right? And it limits pronation. So when you first contact the ground and that arch needs to slightly collapse inwards, if you don't have that good mobility in that talar curl joint to flare outwards, to pronate, you don't have that ability for that foot to, you know, absorb those forces. And then over time, with that plantar fascia is it's constantly in a shortened position, so it just gets tighter and tighter and tighter. And so the reason that happens is we have a higher arched foot or global inflexibility or a history of ankle sprains. So here's what we finally get to, is looking up the kinetic chain. Is, like we said before, too much of treatment is incorrectly focused on the plantar fascia, right? And not enough is saying, okay, what's going on in the knee? What's going on in the hip? What's going on in the ankle that's causing that arch to collapse, for example? Because if we're just focusing on stretching and releasing that tissue, that's only giving you temporary relief. And that's why you're dealing with this thing for several months, because you're not getting at the root cause of why those what mechanics are being affected. So we need to look elsewhere in the body. And a lot of times these stretches you read online may actually cause more of that medial arch collapse and basically make that foot more flexible and contribute even more to your problem. All right, so specifically, let's talk about tight calves. So if your calf is really tight, you're going to limit the foot's ability to dorsiflex or go back. So if everyone takes their foot and bends the toes towards you, that's called dorsiflexion. And so we should have at least 90 degrees towards you, if not more with that. And that allows that foot as we walk to basically for your weight to transfer over to the next step. And if you don't have that, we get problems. And so one study found if you don't have at least 0 degrees of dorsiflexion, you have a 23 times more likely to develop this condition than if you don't. So let's see if I could explain that in a little bit more detail. So same thing, what we talked about is that heel striking the ground. This would be my left foot. If that heel strikes the ground and my weight's starting to pass over my body, and this is that dorsiflexion we're talking about, right? That ankles bend in this way. If I don't have enough mobility because of my calf being too tight, or that what's called your Taylor curl being tight, and that could be because of history of ankle sprains, is your foot's gonna go, okay, where else can I get the mobility? Where else can I move things to allow that foot to bend forward? And so what it's gonna do is it's gonna go back to that subtalar joint. It's gonna go, okay, I want that subtalar joint to kick outwards. You're gonna collapse inwards, and we're gonna make that other part of that foot more flexible to allow that foot to transfer even more forward. But as we just talked about, as that foot becomes more flexible, during this phase of that push-off, you don't want flexibility. So you just created further instability at other joints, and you're stressing that plantar fascia. All right, so one of the things that you could do that I'm going to do is a modified version of your typical Gastroc Soleus stretch that you see all the time, with someone leaning their calf against the wall or whatnot. And it's based on trying to get that joint to move in the opposite direction. And we'll go over a calf release as well to reduce some of that tissue tension in that gastroc. So normally what you see is this typical calf stretch where someone's leaning into the wall and you're just trying to bend that ankle forward to stretch that calf, stretch that plantar fascia. But as we talked about, is if you don't have enough mobility there, your arch is going to start collapsing in, and you're just further aggravating the problem because you're creating too much mobility in that foot. So instead of that talus kicking, that talus is moving outwards, foot's collapse inwards, I want to do the opposite. So I'm going to take my right leg and I'm going to drive it across my body, just like so. And I'm still bending that ankle forward, but as I do this, you're going to feel your ankle roll inwards, your ankle roll outwards, and that heel roll inwards. And that's going to move that joint in the direction that you need in order to supinate that foot. So you're just going here, back and forth, and you could do this for about a minute. All you're trying to do is create mobility in that joint, be able to supinate that foot more, to allow that foot to become more of a rigid lever during that push-off phase. So that's the first thing. And I suggest doing that stretch several times a day. Obviously, if it's hurting and it's making it feel worse, do not, but that's a great stretch, especially for people who have excessive pronation. So the other one would be a calf release. So you could use a foam roll, lacrosse ball, either one, and what you're trying to do is just break up some of that tissue tension in the calf. So what I like to do is I'm going to put my opposite leg on top of my left leg here. I'm going to find a tender spot. And then what I'm going to do is to make it an active release is I'm going to bend that ankle up and down. And this should feel pretty uncomfortable because you're breaking up tissue restrictions. Now I'm going to hang out on a certain spot that feels very tight for about 30 seconds or so. And I'm going to move that foam roll, twist my leg slightly in, slightly out, see where else it feels tight. And then once I find that spot, same thing, up and down. And all we're trying to do is improve that tissue mobility of that calf. So if that calf's not so tight, we don't get those compensations we just talked about before. All right, so another problem area that's happening elsewhere in the body that affects that foot and ankle complex is having weak glutes. So a lot of times it's the opposite glute. So it's called your glute med, or it could be the same glute, either your glute max and glute med. And this is gonna affect the way that arch collapses. So once again, I'm gonna show you a little bit about why that is. So that your glute med is a hip abductor. It basically brings your leg out to the side. So when it's weak, it causes our hips to collapse inwards, correct? So if I'm walking, and still we're using that left foot as an example, and my right hip is weak, everyone try this at home, stick your hip out to the side, and you're gonna feel your left ankle is gonna start to roll inwards, and that arch is going to collapse. And right when you want that foot to push off and not have that arch collapse, it is creating that too much flexibility, and then that plantar fascia gets strained. So this hip being weak is going to affect that left ankle's ability to push off correctly. The other thing that we see is when we run, for example, there's a lot of ground reaction forces. So there's a lot of pounding that occurs. If my glutes aren't strong to absorb all those ground reaction forces, where do they go? Right in my foot and ankle. So instead of that being absorbed in my big, strong glute muscles, it gets absorbed in my ankle. Your plantar fascia doesn't have a chance, and it starts to get irritated. So some exercises you could do for the glutes, I'm going to go over 3. Hip thrust, 90-90s, and some resisted sidestepping. These are really easy exercises to do at home. You don't really need much, you just need a resistance band, and even that you don't. So first one would be a 90-90. So this is to get that glute med muscle that we just talked about. So that's that hip abductor that lifts the leg upwards in this direction. So what you're gonna do is you're gonna line your side. You're gonna bring your hips up to approximately a 90-degree angle here. And you're gonna lift your legs straight up in the air like so. Now the way to cheat with this exercise is if I roll my hips backwards, meaning on my backside, it should say stacked and forward and not be rolling backwards. Because if it does roll backwards, I actually start using other muscles, including my TFL and IT band. So it's not about how high I can get the leg. It's about keeping that neutral pelvis and lifting that leg up, hold 1, 2, 3, and down. And you're looking for about 10 to 15 reps. 3 sets, but you should feel, if you're doing this correctly, that activation or soreness happening right in the glutes, not in the front of your hip, but more in the back of your hip. Like that. So those are called 90-90s. The other exercise I want to show you is hip thrust. So you're going to put a resistance band around your knees. You could find a bench, you could find a couch, chair, anything at home that's somewhat relatively low to the ground. And you're going to come here, you're going to tap your hips and come up this way. Here and up. I'll show you from a slightly different angle. To be here, my shoulders are resting on this bench, my knees are pushed out into the band, then I'm dropping my hips down, I'm tapping the floor, and then I'm exploding up with my hips, squeezing my glutes. And what I want to avoid
is arching my back, because then your back muscles are kicking in and your glutes aren't working. Same thing here, up, 1, 2, 3, down. You're looking for same thing around 10 to 15 reps, 3 sets or so, and you should feel your glutes getting activated with that one. Last one is you're gonna slide that band down towards your ankles. And what you're gonna do is you're gonna stick your butt back. You don't want your knees coming forward this way, right? You wanna stick your butt back so your weight's almost in the middle of your foot. It's not too much of a knee bend. And then what you're gonna do is in that position is you're gonna sidestep. Back and forth. I wanna make sure my toes aren't rotated outwards. I'm not teeter-totting my hips back and forth. And I still have that nice squat mechanic. If you feel this in your quads or in the front of the muscles, it's because you're leaning your knees too far forward. And that's getting your quads instead of your posterior chain activated. So my knees should be more in line with my heels as I sidestep. And you're going same thing, about 10 or 15 reps one way, 10 or 15 reps the other way. And that's to get that glute med muscle activated. All right. So one of the last issues that could happen is low back pain and a lack of mobility in our spine. That's going to cause that excessive pronation too. So first one, if our back's really tight, what happens is it inhibits our glute muscle. And if that glute muscle is inhibited, it affects what we just talked about previously. That foot's going to pronate. It's not going to be a good shock absorber, strain on your plantar fascia. The other thing is it prevents you from rotating your spine. And we need some degree of rotation in our spine when we walk. If we don't, it's going to affect the way that foot supinates or pronates. So let me see if I could show you that one. So my spine's twisting to the right and left, right? So everyone staggers their feet a little bit and twists one direction. I'm twisting to the right. I'm going to feel my left arch start to collapse. Now, if I'm going the other way and I twist to the left, I'm going to feel my arch raise up. I'm going to roll on the outside of that ankle. So if I have good mobility here, I'm getting enough pronation. Because if I'm taking that next step and I don't have any rotation mobility to get me out of that pronation, to supinate that foot, because my lumbar spine's locked, that foot's going to stay in that pronation as I try to propel that foot forward, and it puts all that strain on that plantar fascia and it doesn't have a chance. So as you can see, things are happening elsewhere in the body, whether it's in the calves, in the hips, or in the low back, affect the way and the mechanics of that ankle, and it puts strain on that plantar fascia. So just treating that foot and ankle and just stretching that is often not enough, because we have to address what else is happening elsewhere in the body that's contributing to the problem in the first place. So hopefully these exercises make a little sense. If you guys have questions, I know I threw a lot at you, feel free to ask me or Dan right now in the Q&A part right now. Any questions? I'll give it about another 30 seconds and then we'll wrap it up. All right, so one of the questions here was, what are my thoughts on wearing orthotics? So The literature is a little mixed on this, and you're going to hear arguments from therapists and different doctors with both ways. I've found them to be pretty helpful with certain patients. And especially if we talk about where someone has a really pronated or really high arched foot, where it's outside of their control. It's just, it's not because of things going on in their back or hips or calves. It's just the way that foot type is. I think orthotics are definitely appropriate. But a lot of times is we use orthotics and we think that's going to be the treatment solution, and we're not looking at those other kinetic chain effects. So I think there's an appropriate place for them. I don't think it's for everyone who has this condition, but it's definitely helpful. The other question is, how do you feel about barefoot shoes? It depends. Same thing. So, you know, certain people who their foot's conditioned over time could absolutely do that. But if you've gone 40 years and you haven't strengthened the muscles in that foot and ankle appropriately, and you're getting that arch collapse, because the shoe's going to give you some, at least some arch support, and you're all of a sudden transitioning the barefoot, and your running mechanics haven't changed, you're used to running one way, it's going to really start to, you're going to excessively pronate probably, or if you have a really rigid foot structure, it's going to not be good for those, dissipating those forces, and it's going to lead to some pain. So it just depends. It takes a lot of training. You usually have to start at a younger age, and it also depends on the foot type. So it's an individual decision. I usually work with my clients and determine who would be appropriate and who wouldn't. But obviously, if you transition to that barefoot shoe and you're having pain, maybe it's not for you, or you got to address some other things going on elsewhere in the body. Another question is, if I'm experiencing pain, should I be icing? Yes, you could ice. The reason why I called it plantar fasciopathy throughout a lot of this is they found more and more that there's not inflammation really going on in there. So we always use ice for inflammation, correct? And they found more and more in the literature that it's what's called the plantar fasciopathy. It's more degeneration of this tissue, that plantar fascia, versus it just being inflamed. So if it's really irritated after a long run, I suggest doing that at the end of the day. Otherwise, because what ice is going to do, it's going to cause that tissue to really, really tighten up. And then if you go and walk 2 miles afterwards and it's all tight, you're going to start ripping that plantar fascia apart, and it's going to be really tight and rigid. It's not going to feel good. So at the end of the day, if it's really painful, there's a time and a place for it. It's more just kind of a numbing effect, but I don't think really helps with that inflammatory part of plantar fasciitis or apathy, because they found is not that much inflammation going on. Hopefully that makes a little sense. Any other questions? Let's see. On the calf stretch, you're stepping your front leg across the midline of your body or in line with your back foot. So I'll re-demonstrate. I'm bringing that leg across my body. So to review, is a lot of times that arch collapses too much inwards. Our foot pronates too much. And if I'm really yanking on this foot, and if I don't have enough mobility in my talar curl joint or my calf, that midfoot's going to open up that forefoot, my subtalar joint's going to collapse, my arch is going to collapse in, and it's going to just further perpetuate that problem that's in the first place, is what's going on in your subtalar joint. So you've got to go and mobilize so your heel is going inwards and your ankle is rolling outwards. So to do that, if you bring your leg across your body, you're going to feel your ankle roll on the outside of your foot as you bend that foot forward, like so. And that's going to mobilize that subtalar joint in the direction that we want it to go, in the direction that it needs to go, that it's currently not doing. So the question is, how does using elliptical affect plantar fascia? So obviously the mechanics of elliptical are a little different than running. You're not lifting and making that contact forces, but you are to some degree need some dorsiflexion with that foot. Is that elliptical goes back and forth. So if you don't have enough dorsiflexion, is that foot translates forward and you could, I guess, simulate some of the same problems that we're having here, and that's if you have tight calves and whatnot. Elliptical is a little, obviously, less impactful and less stressful, especially if you have an issue with shock absorption than like fast walking or running. But in theory, it could aggravate it as well, but it's definitely a safer option if you're looking for cardio. All right, any other questions? All right, I think we'll wrap it up. Just a reminder, everyone, next webinar is next Thursday with Garrick, and he'll be presenting on why hip flexors, problems with tight hip flexors could affect things elsewhere in the body. So you're kind of seeing a theme with REACT, and that's our whole approach, is areas elsewhere in the body that lead to pain, whether it's in your shoulder, your knee, your foot and ankle, and not just looking at these specific ailments in that area of the body and ignoring what's happening elsewhere. So hopefully these are helpful in getting people to start to understand the way their body moves and works a little bit more. All right. Thank you, everybody.